like it is going through. Hi, everyone, and welcome to What's Up, Doc. Today we have Florida Cardiology's Dr. Ashish Gupta, an interventional cardiologist, and he's also our Chief Community Advisor for the Global PAD Association. We are very honored to have him supporting us in our communities around the world and helping to guide us in better supporting our patients. Remember that What's Up, Doc is for educational and informational purposes only. Advice and information offered are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this series without the explicit consent from your own healthcare team. And if you are experiencing any leg pain, leg cramps, neuropathy, have toe or foot wounds that won't heal, make sure you do ask your physician to test for peripheral artery disease, those blocked arteries in mainly the legs. And if you think you are having a
Bernie,
medical
wait.
emergency, make sure you call your local emergency number or go to the nearest emergency department. Okay, with that being said, welcome, Dr. Gupta. We really appreciate you being here. Can you hear me?
Yes.
Oh, good. Hello, hello. Thank you for taking time. You've probably had a really long day. And now you have to, continue that day. And I know you're probably waiting for your lovely bride for dinner and to enjoy your pup as well.
I'm actually home alone, and my pup is already throwing tantrums. So,
Oh no. Oh no. Well, we'll
yeah.
get started. We have quite a few questions when everyone found out that you were coming on. Everyone wanted to join our live studio audience or send in their questions already. And so I wanted to kick things off with something that, it was very frustrating for me getting a question last night from the daughter of a patient saying to me, I don't understand why my doctor, my mom's doctor, never actually diagnosed her with peripheral artery disease, yet has done an angiogram, wants to amputate the toe. He's only told her that she has poor circulation and it was because she was old. And I'm curious from your perspective how often you actually hear this these days.
It's actually, believe it or not an uncommon occurrence. I mean, we do see patients who've had amputations of the toes, sometimes even amputation of the leg, and they really haven't had any vascular evaluation. And when I asked them, it's like, oh yeah, my foot had gangrene, so they just went ahead and amputated, which in some situations may be a reasonable thing, especially if they have severe ischemia and osteo, and it's life-threatening ischemia, and you really can't do much. But then you have to have evaluation of at least the contralateral limb, and so unfortunately this still happens, and I tell my patients that you have to advocate for yourself. So if you have any unusual symptom which you can't explain, it could be cramping in the legs, it could be heaviness in the legs, it could be nocturnal cramps, it could be pain when you're walking, or you have a small blister which is not healing, anything which is out of the norm, you should press your doctor to figure out what is going on, especially if you have risk factors for vascular disease, like if you're diabetic, age more than 50, you are a smoker, you have kidney disease, you have already established heart disease, strokes. So you have to ask for these things. So, and I'm sorry for that patient who had to go through that.
It was interesting. Her husband ended up doing a Google search and looking up poor circulation and putting just the words together: poor circulation, angioplasty, and amputation. And then it came up with peripheral artery disease, and they started seeing a bunch on there. And so when they did a grander search, they ended up finding our Leg Saver hotline and calling
Wow.
us, and we were able to get them a second opinion for their mother. But it's interesting that I see this all the time for our Leg Saver hotline in particular. I
Mhm.
recently analyzed some of the information, and we discovered that more than 30% of all the folks that were on deck for amputation, they weren't even told it was peripheral artery disease as being the reason for their amputation. They had every other reason, just
Right.
basically poor circulation, old age, fibromyalgia, diabetes was really the number one reason for this amputation. And so it's still very frustrating. And I'm curious from your perspective, do you hear this in the physician communities from other vascular specialists in your area or in other areas that think that it's better to just tell their patients, oh, you just have poor circulation or it's just because of diabetes that they need to have these treatments?
I mean, it really depends on the setup. So, when I see patients in my office, they are usually coming in either as primary referral from the wound care providers in the area, or they're coming in for second opinions. But in general, when I see, patients who've had prior amputation, whether it is partial amputation of the foot or the toes, or they may have had more radical amputation, like above the knee or below the knee amputation. And I ask them, it's like, hey, why did you get this toe amputated, or why did you get the leg amputated? And unfortunately, many patients, they say, oh, doc, I just had diabetes, and I was told I have poor circulation, and I had, gang gangrene. It's actually really surprising to me that many times patients have no idea why they actually ended up getting amputated. So they don't know the reasoning behind it. And then on top of that, they don't have a proper follow-up, not only for the leg, which was, or the foot, which was amputated, but the contralateral leg. So I just don't know whether some physicians tend to underplay the
Mhm.
impact of tissue loss, amputations, and they just kind of blow it off that, oh, yeah, well, you had diabetes, you had kidney disease, you had a wound which didn't heal, and we just amputated. I think it happens. It's unfortunate. I just don't know how to, change the mindset, except that what you guys are doing, that educate, educate, and educate, and then keep talking
Right.
to people.
Yeah, educate the patients on it. It was interesting
Right.
that I think it was ABC that came out with a documentary on the diabetes epidemic. They really came out with it because it was called Severed. I don't know if you saw it. And it was very good, very powerful. We talked to the reporter who put together the documentary, and the reason he put together the documentary was because it was something that was personal to him. His dad had diabetes, but and ended up with blocked arteries in his legs, and would have ended up, he said, with amputation if he hadn't had a tragic accident falling down the stairs. But when I asked him the question, why do you think that we're having a tough time with doctors, diagnosing these patients as, having peripheral artery disease. And he says, well, I think it's just easier to tell a diabetic it's because of diabetes. And he said, I think that that's the way to go. And that's the direction we're going with the film, is really putting it out there that, hey, it's diabetes that's causing these amputations, and we need to get the diabetes under control. And I understand that school of thought, but I still,
No,
think
but
there needs to
diabetes,
be.
see, the diabetes is the cause,
Right.
right? And you
Exactly.
rightly said that. So, okay, so if you have diabetes, you have dyslipidemia, you have cholesterol issues, you are a smoker. Well, then as a physician, your goal is to not only do secondary prevention, but also do primary prevention, whether it is cardiac disease or vascular disease. So, what are you going to do for the primary prevention? Control the diabetes, control the smoking, control the blood pressure, control the lipids. And, sometimes patients are very resistant. Like I had a guy today, 36 years old, who's had
Wow.
2 heart attacks. So he recently had an MI, had a stent put in his LAD. He's 36, right? So he comes to me and I can smell the cigarettes on him. And I said,
Oh
well, are you
my.
still smoking? And the guy smokes 2 cigars a day, right? Each cigar is equivalent to 20 cigarettes.
No way.
So he's smoking 2 packs of cigarettes a day. So I asked him, I said, has anybody talked to you about how to quit smoking? And the guy said, yeah, they talk about it, but nobody has actually tried to work with him to help him to quit smoking, right? So that's the problem. So, a lot of the guys, and I understand, a lot of the times physicians are busy in their practices. They just don't have time to talk to the patients, but to me, that's actually really not good medicine, because as a physician, my primary goal is to prevent things from happening. So primary prevention is extremely, extremely important. So yeah, I mean, I saw the guy, he had, on all the good medications, his antiplatelet therapies, whatnot, but I literally spent 20 minutes going over why it is so important for him to stop smoking. I made him call the Florida Smoking Quit hotline, gave him the script for Chantix, gave him this, nicotine replacement prescriptions, and he's going to see me every 4 weeks until he quits. So I'm not too worried about his coronary event, because that event has already happened. What I'm more worried about is his next event. He's 36 years old. So I think from patient perspective, I know some of these things are hard, especially in elderly patients, patients who may not have access, patients who may have, a little bit lesser socioeconomic status, so to speak. I mean, it's a weird term to use, but I see that these patients, they are sort of resigned to the fact that, oh, they have diabetes and nothing can be done. Oh, they have blood
Right.
pressure, they can't. But I don't think that is true. I think there are ways to help people get to proper goal, at least try to modify the trajectory of their diabetes or their blood pressure or their cholesterol or smoking. So I think it can be done. It just needs effort, both from the physician side and also from the patient side.
Right. And
So
I think that if you just tell a person it's diabetes, you're getting an amputation because of diabetes. There are reasons why you might need an amputation because of diabetes. There are some serious infections that can happen, et cetera, right? Just from the diabetes alone, you don't feel the foot, you scratch it, and it might not be a general circulation issue. There are a lot of other infections that can occur that lead ultimately to that. But when you tell a patient that you are getting your leg amputated, for example, because of diabetes, when they go to Google search it, you can't find any sort of other option except for amputation for diabetes. If you call it peripheral artery disease, you can find out there are alternative options
oh, absolutely.
available.
Yeah,
And I
yeah.
think that it's doing a disservice to these patients by not calling it what it is.
Mhm. I completely agree. I completely agree.
So with all that being said, I want to get to some of the questions. I know I have some other ones coming in. We have a question from Debbie. If kidneys aren't absorbing warfarin, is it time to treat blocked renal arteries?
No. So the answer is absolute 100% no. So the warfarin metabolism does happen through kidneys, okay? So 92% roughly warfarin is metabolized through kidneys. But if somebody has kidney dysfunction, typically what we have to do is we have to adjust the dose of warfarin so such that the INR stays within the therapeutic range. Renal artery stenosis or blockage in the kidney artery has no effect on metabolism of warfarin. In fact, indications to open the renal arteries are very, very, very limited.
Hmm.
So the indications are somebody who has resistant hypertension, meaning the blood pressure is not getting controlled and they are on 3, 4, 5 different blood pressure medications. And they have had admissions to the hospital with heart failure because of hypertension, pulmonary edema, meaning fluid is getting, collected in the lungs because of high blood pressure. That is the true indication to do renal artery stenting. I see renal artery stents being done in the community for somebody who has 50, 60% blockage. Yes, there is blockage, but blood pressure is 140/70, and they are only on 2 different blood pressure medications. That is not the indication to do renal artery stenting. So to answer your questions, if somebody has renal artery stenosis, and they are on warfarin, you can adjust the dose of warfarin or switch to another anticoagulant, but there is no reason to open the kidney arteries.
Question from Sarah, are blocked carotid arteries in the neck considered peripheral artery disease?
Yes, so it is called the supraaortic disease. So, if you think about the vascular bed, your aorta is basically coming from the heart, making a U-turn, and then going down to the stomach. So this is the aortic arch. So anything above this going to the head is the supraaortic area. So it is sort of peripheral vasculature, but above the neck area. So technically, it is a peripheral arterial disease, but we just classify it as supraaortic or carotid artery disease or intracerebral disease if it is in the smaller blood vessels in the brain. So to extend your question, so there are a lot of trials and registries which looked at people who have disease, let's say in the carotid bed. Okay, so there's a REACH registry. There is data from the Capri trial, the ENHANCE registry. So if you have disease in one vascular bed, whether it is the heart or the carotids or your lower extremities, there is 30, depending on what registry you're looking at, let's say 15 to 30% chance that you will have similar disease in overlapping vascular bed, right? So that means if you have coronary disease, you are at a higher risk of developing cerebrovascular disease or disease in your circulation. In other words, then you need to be extra cautious in getting proper screening and, more importantly, modifying your risk factors.
We always say it's really important to chat. Chat's the acronym for carotids, heart, abdomen for aneurysm, and T for toes. Check those foot
Absolutely. Pulses. Yep.
Okay, Douglas, can you build collateral vessels below the knee by walking?
Absolutely. And we see that all the time. But remember, collateral circulation is great because you're trying to get flow to the area where the straight inline flow is not there because your native original blood vessels are blocked. But also remember that collateral circulation, whether it is in the heart or in the legs or other parts of the body, is not normal circulation. So that's your body's way to get nutrients and oxygen, blood to the area where you don't have it going through the original highway. So if you have good collateral circulation and you are asymptomatic or mildly symptomatic, awesome. We don't have to intervene. You should not get intervened on, but like the mantra on the PAD site is walk, walk, walk. So yes, so you gotta continue doing your graded walking exercises. The only indication to intervene would be if somebody has what we call as critical limb ischemia or rest pain, and they are on maximal medical therapy. then the straight inline flow has to be restored at least to one of the three vessels. But
I'm curious from your perspective and looking at the group, you mentioned the group and our motto is walk, walk, walk. I'm just curious, do you just, it must make you feel so good to see in there how much that you see patients actually talking about building their collaterals. I
yes,
talked to another doctor who was like, I've never heard of such a thing. One of your patients came to me and talked about collaterals. No other patient has ever talked about collaterals until now, until you.
no, it is incredible. It's awesome. I mean, I'm so happy that many patients are getting this concept of the importance of walking and building the good collaterals. So that's really good.
Heinz has a question for you. Heinz, go ahead and unmute.
Hey, Doc.
Hey, Hans.
I go through the forum quite frequently. There was an interesting question posed 3 days ago. Kim gave a really good answer, but I have a question related to that. And I'll read the question. How do your arteries get reclogged if your cholesterol is always normal? Where is the cholesterol that clogs your arteries coming from? And Kim kind of said, in a nutshell, it's an advanced lipid panel that shows you why. Something to do with not the fluffy type of LDL, but small dense. So what can you do about getting rid of small dense LDL?
So this is actually a very good question. So let me answer the first part of the question. Okay. So there are so think about, so you have a highway, okay, and you have a highway where there is a construction going on, all right, and you have a lot of concrete sitting there, and then you just have, instead of a 4-lane highway, you have now a two-lane highway. So it's the same amount of traffic is going through that, right? So similar thing is happening in the blood vessels. So when you have calcified plaque, that there is remodeling going on in the blood vessels. So you have a lot of this concrete build up, and there is same amount of blood trying to go through that narrow hose. So what happens is that when you are doing a lot of activity, when the flow is trying to increase, that narrowing cannot handle that. Okay, so people will have angina, people will have claudication because there is a narrowing in the direct blood flow. Okay, that's where the angioplasty, the intervention, and all that comes into play. Now, once you have intervened, there is a lot of inflammation which happens post-intervention. There is a lot of remodeling which is going on post-intervention. So sometimes because of that excessive inflammatory response, you can develop narrowing in the area which is already treated, whether it is the instant restenosis, so neointimal hyperplasia, multiple different terms, right? So that's one mechanism. The other mechanism is that you have treated the concrete, but then there are other areas where you may have a little soft plaque, right? Or a traffic cone, and you're driving at the night, you didn't really see the cone, and you hit the cone, and boom, you have a car accident, right? So same thing is with soft plaque. So the soft plaque, the blood is coming in with turbulent flow, and it can sort of damage that soft plaque and cause a micro hemorrhage or micro trauma in that area. So that plaque can rupture, and then the body thinks that, oh, I'm bleeding somewhere, I got to plug that hole. That's when the acute clotting happens in the arteries, called the thrombosis. So that's the mechanism of acute heart attacks, right? Or acute limb ischemia. Then we have sudden development of a blood clot. That's an emergency. So that's where you have to treat, with multiple modalities. So those are, there are multiple different mechanisms why you can have reocclusions, whether it is in the original area or a different area, okay? So then the question becomes how we treat it. So right now, the only available modality is to work on the LDL. So we have your statins, we have the PCSK9 inhibitors, we have the insulin inhibitor, the Leqvio, which is excellent. And now we have a newer drug called the bempedoic acid derivative, which is nexletol. So we have 4 or 5 different medications to treat the LDL part of it. But there is data to show that the LPA2, lipoprotein A2 activity or apolipoprotein B, if they are elevated, they increases the risk of having a cardiovascular event. But right now, we don't have any drugs for those molecules. I think within the next 3 years, we will have at least 3 different drugs targeting the LPA2. So clinical trials are actually currently going on right now. And then there are also trials going on to look at the triglycerides, which are the fluffy fatty particles. So we have 2 or 3 good drugs right now to treat that, but there are more monoclonal antibody-based medications which are now under clinical studies. So I think in next 3 or 4 years, the whole treatment paradigm of cholesterol management is going to change very, very dramatically.
Wow.
So, yeah.
Right. So basically, if, it's not just about the cholesterol, then the cholesterol is just a piece of it. And having normal cholesterol doesn't mean that you're not going to reocclude, and doesn't mean that you shouldn't be,
because
on a statin.
so the LPA2, that's genetic. So we're talking about familial hypercholesterolemia. So there are different types. So again, there is no treatment available, right? So I will do the advanced lipid panel in somebody who has higher risk, to kind of sort of risk stratify them, especially in younger patients or patients who have early onset disease or strong family history. And that just tells me how aggressive I need to be in lipid control, if they're diabetic, blood pressure and what have you, diet. But I can't modify their LPA2. I can't modify their LDL pattern type. So there is LDL pattern A, there is LDL pattern B. The pattern B is the one which is more sort of risky, but there is no way for me to modify that. So even if I have that information, unfortunately, right now, as of today, there's not much I can do except lower the LDL.
Yep, that's actually, so as you know, my dad, so when he was at risk, for a heart attack, and he was having some symptoms, the doctor brushed him off as having just indigestion. And I said, well, I think we need to do an ECG. And she said, no, his cholesterol is normal. And I had to educate her that more than 40% of people who, had a heart attack, I think it was 40%, have normal cholesterol in a basic lipid panel. And for my dad, it wasn't until we did the advanced lipid panel that we found out, one, he was pattern B, and number 2, he had a very high LPPLA2. And then number 3 is he had a very large number of the small dense LDL particles, a very large number. It was really off balance with the larger fluffy LDL particles. And the doctor was like, we need to do actually more. They sent him to Boston Heart Diagnostics and found out that he didn't really have a liver production problem for him, but he still needed to excrete some of that out. So he had a cholesterol reabsorption issue. And so he had to increase the soluble fiber, and that seemed to bring it down significantly. So, but each person is so different. And it's good that you ask these questions, and that I really appreciate you taking time to explain all the different aspects, not just with the cholesterol and how it could damage or cause a problem or reocclude, but also when it comes to some of the other mechanisms of action. So that was really important. Heinz, did that answer your question?
Yes, it did. Thanks, Doc.
You're welcome, Heinz.
We have M who's on here. Not sure if she wants me to say her full name, but she is looking for suggestions to help with burning and pain in her thighs and buttocks.
Oh, that's a difficult one.
I had a feeling.
So the question is why, right? So how old is she?
40s.
Guesstimate. I mean, we don't have to be accurate.
40s.
54.
Okay.
No, you're
So,
not.
so,
45.
so the question is why, right? So there could be, so if you're, diabetic, if you're obese, you could have neuropathy just from diabetes, right? You could have, and again, I'm kind of going over the non-vascular causes first, right? So you have to figure out why. So is there like a lot of scoliosis? Is there a lumbar spine problem? Is there a radiculopathy? Is there like a nerve compression which is causing it? When is the burning happening? Is it all the time, or is it with ambulation? Is it more towards the end of the day? Is it sort of generalized in the entire leg, or is it just in one particular area of the leg? So this has to be obviously, examined and then talked about in more details. But if you do have risk factors for peripheral vascular disease, now I'm using it like a global term, so then I think you should basically start with getting a routine like ankle brachial index with and without exercise to see if you have arterial disease. If you notice that your legs are more swollen towards the end of the day, you have a lot of superficial veins, you have maybe varicose veins or spider veins on the legs, and you have a lot of cramping, then you could get evaluated for venous insufficiency. But just burning and tingling sensation, that could be any number of things.
And that is even if you do have PAD, we have all kinds of things that could end up, causing some of those. But she says she knows it's actually from the pad. But any suggestions potentially to relieve some of those symptoms? She's trying to delay having a procedure. She's trying to walk and push things a little bit further each and every day.
I think so if it is just the neuropathy where you have a lot of burning sensation, obviously if you're diabetic, you want to make sure that your A1C is less than 6.5. So that is very, very important. But then there are medications like gabapentin or pregabalin, which can help with neuropathy. Problem with these drugs is that they do make you very dizzy, very sleepy, so some people don't tolerate it. And then some people sort of develop resistance, so to speak, so you have to up titrate the dose. Then there are certain antidepressants which can be used, like amitriptyline or duloxetine, which can help. A little bit of massage, like Epsom salt baths, things like that will give you sort of temporary relief. Unfortunately, there are not too many medications who truly help, like eradicate the underlying problem. They may help you symptomatically. Sometimes, getting tested for like vitamin B12 deficiency. So if you have that, fixing that will help. Taking magnesium supplements may help. And if you truly have PAD, then I've seen a very good response with cilostazol, Pletol. So if you're not on Pletol, then maybe getting on low dose of Pletol, 50 milligrams twice a day, and then increasing it to 100, that will help. If you have a lot of restless leg type syndrome where you feel like you have to cut your legs and hang them on the wire, you have to get up at night because your legs just cramp up and you have to get up and walk to feel better. That's called restless leg syndrome. So if you have that, then you should get tested for sleep apnea, because there is a direct correlation between that. And then you can also ask your doctor to get on a medication called Requip or roperidol, which is excellent medication for RLS. So it's sort of hit and trial, what works for individual patient.
And we have Marcia has a question. Marcia, do you want to unmute or do you want me to ask it for you?
Bernie,
There you
wait,
are.
baby.
Hi. Thank you, Kim. I'm wondering how can a PAD patient manage their PAD as they manage other leg issues? So like for me, I don't know if it's arthritis or what, but my knee's acting up really bad. So I'm walking less. I'm still walking, but I'm walking less. But I'm concerned about walking too much and maybe really injuring my knee to where
Bernie,
I can't walk at all.
Kim, 1 second. I'm sorry, Marcia.
Okay.
I'm gonna log on my phone and I have to take my pup for his walk because he's driving me crazy right now. So just
I love it. And we get to see his puppy. And this is great.
I'm so
walking
sorry.
is-
He's like,
No, it's
time for a
awesome.
walk. Okay.
He's leading by example. Walk,
Yeah.
walking builds
So,
those collateral
I'm
vessels.
gonna disconnect from my iPad and I'm gonna get on my phone. So give me 2 minutes.
Fantastic. No, I think it's great. And I'd like to actually, I don't know if Marlene minds if I put her on the spot for a second. She is a great example of a walker out there in Florida and actually sees Dr. Gupta. Hi, Marlene.
Hi, yes, I'm so lucky that I'm doing well. I'll see Dr. Gupta on June 6th.
Oh, fantastic. How often do you see your vascular specialist being Dr. Gupta?
Well, he did surgery on me on January 26th, I believe it was. And then I saw him twice after that. We did have a problem with the closure. And
yeah.
and
those actually happen
take care of it.
frequently. I think I saw a statistic in one study that was 1 in every 30 or 32 even.
He did a
Closure
different,
devices end up fail.
no, he did a different procedure because of how long the commute is for us to we don't exactly live in Orlando. It's like an hour and a half away.
Yeah.
So but I'm doing very well. I think he'll give me a good report.
Oh, good. And you're out there walking. I want to see you out at Disneyland. I want to see lots of pictures.
Yeah, we go to Disneyland a lot. Yeah.
Yes.
But Wes and I are both lucky that we have Dr. Gupta.
We always talk about how tough it is, to really push through. And one of the things from the moment I met you, you've been such an inspiration. And some people, if you recall, from the very early days when you would post and say, I'm walking this much and look at this. And people were actually very critical of you, when you were posting and saying, well, what are you doing here? Why are you here with this? And it's like, wait a minute, you don't understand what she's going through to get those steps.
I'm very fortunate that my doctor in Virginia, Dr. Howard, they saw me immediately. I couldn't get anywhere with the primary doctor because they kept pushing my
Okay,
appointment.
I'm back.
And hi,
And we have-
Dr. Gupta.
Hi,
She's
how are
telling
you?
a little bit of her story that she was very fortunate.
We're very lucky that we have Dr. Gupta, but
Oh.
I'll let him speak.
Okay.
See you
So
next time.
Marcia, you had questioned, right, about the knee. So, knee arthritis is not an uncommon problem, especially as we age. So if you have severe arthritis of the knee, which is limiting your ability to walk, you need to get that addressed. There is no contraindication to get knee replacements if you have peripheral arterial disease. Absolutely no contraindication, okay?
What is that? Meaning that you can get the surgery?
You can. I mean, I have so many patients who've had successful knee surgeries with PAD. There is no contraindication. Because remember, the knee circulation, even if you have blockage in the superficial femoral artery, for example, your profunda, which is the backup artery of the leg, can provide excellent collaterals to the knee area. So these are called genicular arteries. So knee replacement in patients who have PAD is not contraindicated, okay? So So if you are arthritic, you have severe knee pain, which is making you to making difficult for you to walk. You gotta talk to your orthopedic surgeon, see if they can do any minimally invasive procedures like knee injections. Injecting Simvisc. It's like gel between the knees. Okay, if that is not helping, you could definitely talk about knee replacement, which is a definite option. And patients actually do really well with knee replacements these days. There are actually, and I'm not an orthopedic surgeon, but there are different approaches for knee replacement. There is one which is the lateral approach, which some of my patients who've had it done here in Orlando by one of the orthopedic surgeons, they say that their recovery time was very, very quick. And they've done really good with that. If knee is not an option, there are now a couple of IR guys who are doing genicular artery embolization for severe knee pain. That's an option as well.
I didn't get that.
Okay. So there are multiple modalities which are there.
There are some interventional radiologists that have this other alternative procedure, genicular procedure, you said.
Yeah.
Can you just describe how that works? We have had IRs on before that have mentioned it, but if you can give us the quick.
So basically what it is that you find out just like, so the knee pain is because of local inflammation and local cytokine production, right? So there is sort of vascularization. So the area of the knee where you have the most pain, if you do selective angiography of smaller blood vessels, taking the blood to that area, you will find that there is a cluster of very, very small blood vessels at that point, which is the tender point in the knee. So what we do is we engage the feeder blood vessel to that area, and we can put glue or particles, very, very small microparticles in that small artery and close it. So basically you take away the blood flow to that part of the knee. So that is called genicular artery embolization. And it has some good results actually. But not all IRs are doing it. It is, very selective, but definite option.
I think it's really important. We see so many of our patients that wait way too long, and then they can't walk anymore.
Yeah.
And as you know, you need to walk. Walking is your lifeline. Walking is everybody's lifeline. Walking, I mean,
Right.
at least moving, getting movement. And if you end up with a knee injury and you can't walk, then that's going to be trouble, as you know. So
Correct.
it's good for you for bringing that up, and I think it's really important for others to know as well. I wanted to go to Rose.
I would not wait. So if you're limited by your knee, get it fixed.
I want to get to Rose. Rose, do you want to unmute or do you want me to ask your question? Rose?
I can ask.
Go ahead.
Hi, how are you? Good evening.
Hello.
I just have a question. I have two questions. I just wonder, I just got diagnosed with CAD, and every day I'm a little scared. I just want to know what tests should be done. I got CAD in the neck arteries. And
Yep,
one of them.
Is it's your carotids, right?
Yeah,
or is it your vertebral? It's your carotids.
They didn't even tell me a specific name yet. I think it's carotid. No.
Mm-hmm.
So it's in one the left. I just wonder what kind of exams, because I was reading a little more about it, because I just kind of find out about it, about pieces breaking off. Like what kind of exams they should do on me to avoid any kind of stroke or heart attack? Like,
all right. So you have the carotid duplex. ultrasound done already?
I already had that done. And
Okay.
yes, that's
So what was the blockage? What percentage did tell you?
they say it's from 59 to, I think it's 60 to
Fif-
79.
50 to 69. That's typically what it is.
Yeah,
Okay,
hers
so
says, is it 50 to 70? I
79.
think he said 79. Yeah.
79. But then
69. 50 to
the
69.
Is
the
it?
six so the CT scan says 70.
Okay, so you have moderate to severe carotid artery stenosis. So one thing is that you need to be on aspirin for 100%, right?
Yes, I
And
already
then you need to make sure that your blood pressure is always well controlled. So how
Mhm.
old are you?
I'm 50.
50. So at least less than 130 over 80, right? Then if you're diabetic, you gotta control your diabetes.
No
Obviously, you
diet.
need to be on good. So you need to be on moderate to high intensity statin therapy. So your LDL, which is the bad cholesterol, needs to be less than 70, or I mean, I even pushed it to less than 50. Okay.
It's 43.
Awesome. Wonderful. So your good cholesterol should be more than 45,
It's
which I
55.
think, oh, beautiful. So, all right. So you have all the good stuff going on for you. Now the
Mhm.
question is, when do we intervene? So if you have any history of, mini strokes or strokes, then you have indication to fix the carotid artery right now. But what you need is you need to have annual carotid Doppler
Yeah,
or a
they're
CT
doing that.
scan. Yeah. And then once it gets to about 80%, even if you don't have any symptoms of TIAs, etc., I think you still these days it's like class 1 indication to even fix asymptomatic carotid artery stenosis, which is 70-80%. But I would not rush for intervention right now. Just focus on primary prevention and annual follow-up.
The reason I kind of
So
get like a little lightheadedness and headaches a little bit.
typically, the carotid artery occlusion will not cause lightheadedness. So
No?
lightheadedness will happen if you have vertebral artery insufficiency.
A what?
So vertebral arteries, those are the two blood vessels which are running in the neck spine area and going to the back of the brain. That is what is controlling the balance center of the body. So if you have carotid artery stenosis and it is affecting your sort of middle artery, middle or anterior cerebral circulation, you could potentially have like little dizziness here and there. What I would recommend is you should get a CT scan of the head to make sure that you don't have any small, like sort of mini strokes, things like that. So that should give us a good baseline. And then the other thing is, headaches, again, is multifactorial. So you have to figure out whether the headache is like a tension headache. Is it more vascular headache? Do you have headaches when your blood pressure is high? Do you have sleep apnea? And
I
you
do have
wake
sleep
up?
apnea.
Okay, so then you gotta make sure that you're using your CPAP because when you are, huh?
Okay. Yes, he started this, but he hasn't given it to me yet.
Okay, so I'm glad they're working you up. So sleep apnea and headaches and high blood pressure, atrial fibrillation, these are all related. So I think you're on the right track. You're getting everything taken care of. Follow up with the imaging in another year. But if you've not had a CT of your head, not an unreasonable thing to ask for that.
They did. It came out good. The CT scan came out good. The head.
Oh,
Oh, good.
beautiful. Yeah.
So thank you so much. That was good
You're
information. 'Cause I've
welcome.
been scared. I've been so scared every day. I don't know. I just scared about the loose plaque, or I don't even know. It's just
No. So you are on the right track. Your numbers are good.
Okay.
Just keep on your medications and, have a follow-up.
Thank you so much.
You're
Thank
welcome.
you, Rose.
Thank you, Kim.
We have a question coming in from Joey, who says, I go in on the 29th of this month to find out if the doctor is going in to clear the artery in his leg. Has anyone had this done, was his first question. But if so, how bad is it and how long will he be down for? I'm curious, I always defer to the doctor to answer the question versus just fellow patients. So I'm curious, from your perspective, what does one expect in, when you go in for an intervention, endovascular procedure with the wires and balloons, and what questions should a patient ask before they go in for those procedures, and even in choosing the right doctor to do the procedure?
Right. So let me answer his question first. So every patient's experience is different, okay? There is obviously, if you're going through a surgery, even if it is minimally invasive, you are in a sort of an alien space. You're covered head to toe with this blue drape, and you're people talking about you, but you can't really understand what is going on. So all of that is sort of expected. Many patients have sort of different experience. So let me just tell you, there are a couple of steps where you may have discomfort and what to expect, okay? So the first thing is, when you come for a procedure, whether it is in the hospital or OBL or surgery center, you're gonna have nurses, they're gonna undress you, they'll put some IVs, get your vital signs, and get you prepped. They'll shave your groin. So it's, sort of a dirty bikini, Brazilian waxing, but it is done, right? So after the prep, you're taken into the cath lab where they will clean both of your groins. And if the doctor is planning on going from the foot, they might, clean the entire leg, which is being worked on, keep the foot exposed. And then, they will call a timeout where they will say, it's this so-and-so, and this is a procedure. And then the doctor will give orders for sedation. Typically, when we do these procedures, we don't we don't put patients to full sleep. Some doctors do that in the hospital. They'll put it under general anesthesia. I think that just increases the risk. Very, very few patients really need general anesthesia. But typically, we will give you Versed and fentanyl. So Versed is a sedative, and fentanyl is a short-acting painkiller, and that's to keep you very comfortable, okay? And the idea is that you should be comfortable enough, but at the same time be able to talk to the physician and your nurses and respond to their questions. And also, we don't want too much sedation, which can then, cause drop in your blood pressure or respiratory rate, especially if you have sleep apnea, things like that, okay? So once you're sedated, the doctor will come in and they will get access, whether it is the left groin or right groin, depending on what they're planning on doing. So this is the first step where you will have some discomfort, because this is a step where we're going to inject lidocaine to numb the area, okay? So it's kind of like going to the dentist. There is intense burning, and typically within 3 to 4 minutes, the area gets pretty numb and you should not really feel anything. Then once you have the area numb, we typically take a needle and puncture the artery and then put a little tube in the artery. So that's the step where some patients will feel a little pressure. And if patients have had multiple interventions, and they've had, scar tissue, then that can be a little bit uncomfortable. But after that, you really should not have any pain, for the angiography. Now, many patients, when you inject contrast, and especially if it's a bolus of contrast, you will feel a warm sensation in your body. Some people feel that they may have actually peed, but that's not the case. And you know what? In reality, even if you peed, what the hell? I can't see it. You can't see it.
That,
It's,
I have to tell you, Dr. Gupta, I'm so glad to hear you say that, because literally 2.5 years into working with peripheral artery disease and everyone having their CT scans, not once did anyone tell me that there was that sensation until I ended up in the emergency room with COVID. And then they were concerned. They put me in a CT scan and they pumped in the contrast fluid. I felt like my whole head was imploding, and I thought I actually truly wet myself. And I was embarrassed. I thought, was this the COVID? Like, what made me just wet myself? I thought, am I really sick here?
No.
I didn't want to get up. I was mortified. And then I moved around a little bit and
No.
realized that
Some
it was
people like it. Some people say, hey, doc, can I have another slug of contrast? It's like, no. so anyway, so then if you have really calcified, very small blood vessels in the leg, particularly below the knee, sometimes when the contrast reaches that area, or if you're using carbon dioxide, if somebody has kidney problems, then transiently the contrast is going to replace the blood, and you will have lack of oxygenation to that area, and that can be uncomfortable. Okay, typically that pain will last for about 15 to 20 seconds. When I tell my patients, okay, if you're gonna feel that, just try to hold still while the picture is being taken, and then you wiggle your toes, and usually the pain dissipates. Okay, so that's the area of some discomfort. Then when we are intervening, especially when we are doing the ballooning part, where we are stretching the blood vessel which was previously closed, and we're trying to stretch it open with the balloon, you can have some discomfort. Remember, there are no nerve endings inside the blood vessel. But when we're stretching, the nerve endings which are around the wall of the blood vessel, they can feel the stretch and you can have some pain. So again, remember that most of the times the balloon is going to be up for maybe 2 minutes, maximum of 3 minutes. And if you're having a lot of pain, then we typically will tell the circulating nurse to give you more pain medicine and keep you more sedated. So that's a step during the intervention when you can have some discomfort. Post-intervention, during the recovery, a lot of the times, at least in my practice, I put a plug in the artery so the patient can sit up early and then go home early, or we put a little stitch in the artery. But sometimes that's not possible. And then when you pull the sheet, you have to hold almost occlusive pressure. That is the step where you are going to have some pain, because what we are trying to do is press the artery against your sort of pelvic bone to stop the bleeding, okay? And that pressure, typically, you will have to hold at least 20 to 30 minutes. Sometimes it can be longer depending on how much a patient may be bleeding, right? So if that is the case, then that 30 minutes is going to be very uncomfortable. And again, we can give you pain medicine during that time. Typically, we'll ask the nurses to give some morphine. And then you have to kind of lay on your back for 2 hours and then sit up and then go home. So people who have chronic back pain, and they've been on the cath lab table for 2-3 hours. That can be uncomfortable. So that is sort of the intra-procedure and immediate peri-procedure stuff. When you go home, you can have some discomfort in the groin or in the foot where we access to get the tubes in. If you've had an intervention, whether it is balloon angioplasty or stenting, you can have some residual pain in the thigh or in the calf area. And you can have some swelling, especially if you've opened up a chronically blocked artery. That's called sort of post-perfusion injury. That's not uncommon, but it can certainly be very uncomfortable. So, if you have some Tylenol at home, you can take that, keep your legs elevated. Sometimes if I know that the patient is going to be uncomfortable, I'll give them some analgesics like tramadol to go home with. I try to avoid opioids at all costs. Very rarely I'll give them just because A, sometimes it's not needed, and B, it's just hard these days to write for opioids, especially for more than 3 days. But typically I just avoid opioids. So tramadol works better. And if somebody's intolerant to it, then I'll obviously use opioids if necessary. So these are the steps. And then typically 24 to 48 hours later, you should be able to walk and resume your normal activities like you were doing before the procedure. So I hope that answered your question. And, like every patient is different. They have their different pain perception. But, this is sort of the standard progression of the procedure when you are in the cath lab. So just don't be scared. Ask the questions up front. Ask the doctor when you are talking about, going through the procedure. So, okay, what is the plan? How are they going to access? Which artery they're going to access? Which side of the groin you're going to go through? What is the backup plan if they can't, open the blood flow? Are they planning on accessing the foot, or they're going to try, if they can get through the blockage, are they going to try one more time, or are they going to send you for a second opinion? So these are genuine questions which you should ask before you go to the cath lab. So be honest with the patient, with the doctor. And, if you're asking honestly, and after all, it's you are the prime person. So no reasonable doctor should feel offended that my patient is asking me these questions. In fact, I think it's really healthy that you have this honest sort of pre-procedure discussion with your physician. And
Any
if
other
that
questions?
doesn't answer, then you can call Kim, and then Kim can call me, or you can text me, and we can take care of your concerns.
And we'll also give you quite a few questions as well that we can customize to your presentation of disease and to your situation, whether you're having an endovascular procedure or whether you're having a bypass endarterectomy or even an amputation. We can help you make sure that you're comfortable before you go in with the right questions. And I love, Dr. Gupta, that you said that a good doctor would love to answer those questions and take the time for you, especially before a procedure. They don't always have the time, but I know doctors like Dr. Gupta that are truly patient-centric and very passionate about what they do and really care about the emotions of their patient. They'll get on the phone later. They'll say, hey, you know what? I have a lot of cases. I'm really in a rush right now. Can I give you a call later when things slow down? And a really good doctor does that as well. And Rose says that you're so amazing for answering all the questions, and we need more doctors like you. And Marlene is here, as you saw, and
Oh,
she
you're
says
welcome.
hello.
My pleasure.
And we have Roxy who came in
Yes.
here, and she just got home from her surgery, had a few stents in both the iliac and the femoral. She's doing some bed rest for a few days, but I'm glad that you said that within 24 to 48 hours, you should be up walking. So hopefully she'll get a few steps in following that procedure, because it's not just about having the procedure, it's only temporary. You got to walk. And then
Correct.
we have Marcia has one more question here. Can PAD cause extreme fatigue?
Well, yes and no. So yes, because, if you're just in such miserable pain because of your claudication, you're not going to move. And then, yeah, you're going to feel fatigue just because you're not physically active. But chronic fatigue can be multifactorial. It can be nutritional. It can be hormonal. Your thyroid is not working. It could be anemia, which is not an uncommon thing in patients who have PAD, because a lot of these patients also have chronic kidney disease or anemia of chronic disease. They can have iron deficiency that can cause fatigue. So I think if you have that, we have to check your nutritional status. We have to make sure if you have anemia, it is corrected. And then, in my practice at least, I have diagnosed so much sleep apnea, which is probably one of the most common causes of daytime fatigue and somnolence or sleepiness. That is not even funny. People really don't recognize it. And I'm telling you, if you have sleep apnea, you get tested for it. And if necessary, if you get on the CPAP, your life will change forever. It is really dramatic how much people feel better once their sleep apnea gets treated. So there can be many, many reasons for fatigue. And I think that, you should talk to your doctor and get checked out.
Fantastic. And we have one more question. We have Douglas. Douglas. And I think Douglas just might have popped off there.
I'm
He
back.
is. Okay,
Internet problems all day.
Oh, I thought
technology.
Stella took off and you were going after her.
Can I ask a cardio question?
Sure.
So what's happening right now is if I put my left arm in certain positions, it feels like I have I'm going to say this word, it feels like I have a vibrator in my heart, on the whole left side of my heart.
Yeah.
So if I'm leaning on my arm, if I do woodworking. So if I use my left hand to guide my right hand when I'm wood burning and drawing. But now every time I use my left hand to help guide my right hand, I feel this vibrating in my heart, the whole left side of my heart.
So, Doug, you want my honest answer?
Well, yeah.
So I think I know your history, so I'm not going to say it, in public, but what you're feeling is not an uncommon thing, which I hear from patients who have, instrumentation like you do. Okay. So that doesn't mean that there is actually something going on.
Right.
Okay. So I would not pay attention to that vibration, because the heart doesn't vibrate like that. Okay. If you do have an electrical issue in the heart, that would immediately show up on your device, and that can be addressed. Okay. So
cool.
if you have rhythm problems, the circuit problem of the heart, that can be picked up on the device. Okay. But and we can talk offline. But I would not worry too much about. I think you are awesome with your woodwork and what everything you do for everybody else. Keep on doing that, and you are fine. Cool. Okay.
Thank you so much, Dr. Gupta. We really appreciate your time and dedication and passion for helping, not only your own patients, but our entire community around the world.
My
And
pleasure.
Sally King, who's watching through YouTube, says thank you, Dr. Gupta, and to me for a great presentation. So we'll let you enjoy the rest of your evening, let you walk your dog, and you're doing a great job leading by example.
Third mile on, so we are doing good.
I love it. I love it. Thank you so much, Dr. Gupta, for everything. We really appreciate it.